Hello, everybody. It's Dr. Eric Walcavage, and we're back for another edition of Thyroid Answers podcast. And today I am joined by myself. Dr. Erica could not be available, and I did not have a guest scheduled for today. So I wanted to make sure we got our second podcast in for January 2021. So today I want to talk about a topic that I think needs some discussion, and that is what tests should be or need to be run to assess thyroid physiology. It seems that everybody you talk to has a different opinion on which tests need to be run to assess thyroid physiology. So which one should it be? Should it be just TSH? Should it be TSH and T4? Should it be a full thyroid panel? What should it be? You'll hear often a lot of disagreement, even within functional medicine, as to which tests are important, which ones should be done, which ones shouldn't be done. And so I think what we need to do is have a discussion, a little bit more of an in-depth discussion. I did a Thyroid Thursday on this, but I only had about 10 minutes that I could give to it. So we're going to have a little longer discussion today. It's kind of odd because I'm usually working with Dr. Erica doing this presentation or have a guest, but I'll work my way through this process. So let's start with just the general question, like which test should be run when you're trying to assess thyroid physiology? And that answer isn't necessarily clear cut. The answer that probably makes the most sense is it depends, okay? It depends on a couple things. It depends on what type of doctor you're seeing, whether you're seeing a medical doctor, an integrative physician, or a functional medicine doctor. It depends on what they're trying to identify. While your allopathic physician may be just concerned about whether you have primary hypothyroidism, which they only need to really look at TSH and a free T4 to determine if you have primary hypothyroidism. Are you working with an integrative physician who is looking at how well T4 is converting to T3, not just whether TSH has been lowered with medication and if T4 is normal, but actually is that T4 converting efficiently to T3 to support the cells and tissues? You might be working with a functional medicine practitioner who really wants to know big picture thinking, what's happening with thyroid physiology. And to me, looking at all the available thyroid tests in conjunction with a full comprehensive thyroid panel or a comprehensive metabolic panel and the rest of their health history and their timeline becomes important. So what somebody's looking to identify determines what they're testing. I'm looking to determine, does the patient have tissue hypothyroidism? Do they have low levels of thyroid hormone in the tissues? And if they have signs and symptoms of tissue hypothyroidism despite a normal TSH, a normal T4, normal T3, then I know I need to get to work trying to identify what is causing the body to downregulate thyroid hormone in those cells and tissues so that we can get their body out of a danger response and actually restore normal homeostatic regulation versus having them continue in what we call allostatic regulation. Another factor that may come into play is, what somebody's philosophy might be regarding hypothyroidism. For many people, they believe that hypothyroidism is a glandular thing primarily, that it doesn't start until the gland doesn't produce enough hormone for the bloodstream. And then the reason you have hypothyroid symptoms is because you didn't have enough thyroid hormone in the bloodstream to support the tissues. And the philosophy is as long as you put enough thyroid hormone in the bloodstream, you're going to fix the tissue hypothyroidism. I don't agree with that model, but if that's what somebody's thinking and believing, then they may only care about what the TSH is and what the free T4, free T3, or the total T4, or the total T3. They just want to know that there's enough in the bloodstream. The other thing that may come into play is, I should finish off with that, is, so some may have the philosophy that's about a glandular thing process first, which then results in decreased thyroid hormone in the bloodstream, and then that results in a lack of thyroid hormone in the tissues, and that's what creates the symptoms. I look at hypothyroidism from a different perspective. I think that hypothyroidism typically starts in the cells and tissues due to what we call a excessive stress response, which triggers what we call a cell danger response, which shifts the physiology of the cell away from growth and development and towards cell defense. And the way the cell shifts between cell growth and increased cell metabolism to slower cell, to reduce cell growth and reduce cell metabolism and upregulate the immune inflammatory process is by decreasing the amount of T3 inside the cell. And I'll talk about that in a little bit. So depending on how somebody's looking at thyroid physiology, they may be thinking, hey, as long as I fix the gland and put enough thyroid hormone in, I'll be good. Or they may look at thyroid physiology like I do and say, it doesn't really matter how much thyroid hormones in the bloodstream if the tissues are resisting it, if the tissues are deactivating that thyroid hormone. And typically with my patients, I use the analogy that if they have a car that's got 3/4 of a gas tank full of gas, but the car isn't running well, and they fill up the tank, does that mean the car is going to run better? Probably not. If the spark plugs are bad and the fuel filter is bad, it's not going to make the car run better just because there's more gas in the tank or more gas in the fuel line. There's something wrong at the engine that's preventing it from running. When we put more thyroid hormone into the bloodstream, normalize blood values, but the cells are still hypothyroid, then we have to understand that there's something happening at the cell and tissue level that's not upregulating that thyroid hormone, that's not converting T4 to T3. And we have to stop thinking that our body's always making mistakes and understand that this may be a calculated adaptive response, which really to me makes the most sense than just broken physiology, okay? So the fourth thing to consider is what's the goal of treatment? That too determines what tests might be run. If the goal of treatment is just to normalize TSH and T4, then those are the only two tests that you may need to run. If the goal is just to normalize TSH, T4, and T3 in the blood, then you may only need to run TSH, T4, and T3. If your goal was to say, hey, I am trying to lower reverse T3 with my treatment, then somebody might want to run reverse T3. If somebody's goal of treatment is to lower or suppress antibodies, they may want to run thyroid antibodies. So it really matters what the goal of treatment is. Not that anybody's necessarily wrong. I may not agree with their treatment strategy, and some medical doctor may not agree with my strategy, or another functional medicine practitioner may not agree with my strategy, but we are looking at tests based on, you know, what the goal of treatment is. In allopathic medicine, the goal is to create biochemical euthyroidism, which means that you normalize TSH and T4. Just get that gas tank filled up and get the gas gauge on full, and then the assumption is that everything will work. And unfortunately, many times it doesn't. And then the last thing that may impact what tests are run sometimes is who's paying. If you're asking a medical provider to run a bunch of tests that they know insurance isn't going to cover, they may not run them. If you're asking a medical provider to run a bunch of tests that they don't ever really use, they don't have any, you don't know how to interpret those values, they're going to tell you that those tests are unnecessary, or they're not medically necessary, or they don't feel comfortable running them, and maybe insurance is going to cover them. So, you know, if you're paying for the test, then maybe somebody doesn't care to run them. But typically, you're going to see blood work run to assess thyroid physiology based on the type of doctor, what they're trying to identify, what the goal of their treatment is, who's paying for the care, and what their philosophy of treatment is. Okay, so let's talk about just like a standard allopathic physician. What are they typically going to run? They're typically going to run a TSH and typically a free T4, or they may run a TSH with reflex to free T4. And so what that means is if TSH is out of lab reference range, high or low, then it's going to, the lab is automatically going to run a free T4 level. If your TSH is elevated above the lab reference range, then we're looking to see where's that free T4 level. If TSH is high and TSH is low, then that fits that criteria of primary hypothyroidism. And in that situation, the doctor now has justification to treat you. And typically what you're going to get in a traditional allopathic medicine practice, whether it's a GP or an endocrinologist, is some type of T4. And to me, in most situations, I think most people do best on a T4 therapy. I used to kind of consider that maybe T4, T3 was a better option, but the longer I'm in practice and the more I see people struggling with thyroid medication, I think if you have a level of tissue hypothyroidism that is persistent, and then you get thyroid hormone, T3 creates more problems when there's a persistent tissue hypothyroid status or a cell danger response going on than T4 does. So I usually am more in favor of somebody doing T4 therapy to kind of manage the crisis while we address the root issues that are causing the cell danger response, the tissue hypothyroidism, and actually probably drove the primary hypothyroid condition. But from an allopathic standpoint, a medical doctor, those are really the only two tests, TSH and free T4. Those are the only two tests that they need to determine or diagnose primary hypothyroidism, and the only two tests they really need to treat and manage your hypothyroid condition. So to ask your medical doctor to run more than that, they're likely going to tell you those tests they're not important, they're not medically necessary, there's no value in them. And in their paradigm, in their perspective, they're right. I mean, there's nothing else they're going to do. If you have an allopathic physician and your free T3 is functionally low, they're not probably going to change their treatment as long as TSH is within the reference range or they've driven it below the reference range. So I don't think you should expect a traditional allopathic physician to run more than a TSH or free T4. And I think you're often putting them in a tough position when you ask them to run more tests than their guidelines tell them to run, the insurance may allow or tell them to run, or they feel comfortable running. So if you really want more than traditional allopathic care for your hypothyroid condition, you probably want to see an integrative or functional medicine practitioner and let them order the blood work that they feel comfortable using as a tool to evaluate and assess you, okay? That being said, what about an integrative physician? What tests might an integrative physician typically run, or a functional medicine physician? Well, typically when I consider what's an integrative physician, I look at the integrative physician maybe as the kind of that bridge between allopathic medicine and functional medicine. And so what's the real difference between allopathic and functional? Allopathic medicine, I think their strength is in crisis care, acute care, and disease management. I think functional medicine is really about root cause medicine. What's going on in somebody's diet and their lifestyle that's contributing to cause excessive cell stress, that's causing their body to adapt its physiology and cause it to start to show signs and symptoms, to show dysfunction and eventually show disease. Is it that you can only do allopathic medicine or functional medicine? No, I really do think you should have an allopathic physician who's there to help you with crisis conditions and insurance-based care. And if you're a person who wants disease management treatment or needs disease management treatment, that's what your allopathic physician should do. Functional medicine is not about necessarily acute care and crisis management. What our job is to help you identify what are the things in your diet and lifestyle that are probably contributing to reduced health, help you change those things, and help you restore normal physiology, so you don't need crisis care, so you don't need disease management treatment for the rest of your life. Our goal should be to get your health improved or optimized to a point that you need extremely little, if any, medications to be able to go about your daily life or daily activities. And so we have two different roles, two different jobs, so that you can have and probably should have both a functional medicine and a allopathic physician as part of your healthcare team. What tests they run are probably going to be different. The lab ranges they look at are probably going to be different. How they go about helping you and treating you are going to be different. And you shouldn't expect those two paradigms or thought processes to be exactly the same. So understand that both practices, or both functional medicine and allopathic medicine, I believe, have a place in healthcare. And so integrative medicine is often the kind of the middleman. Like, I take some of the things from allopathic medicine, and I take some of the concepts of functional medicine, and they blend them together, okay? And so to me, I think that's fine, depending on what's going on. But what I see when it comes to functional medicine or integrative medicine in thyroid care, what I see is that typically, if you're going to see somebody in integrative medicine for thyroid care, they're usually the person that is prescribing combination therapies, more T4, T3 compounds, maybe a nature thyroid, an Armor, an NP thyroid, or they're the person who's giving you T3 medications as part of care. Now, why would they do that? Why would they do that instead of doing T4? Well, typically, I think what happens is people get diagnosed with primary hypothyroidism. They get prescribed T4 medication. The medication brings them back into biochemical euthyroidism. So TSH normalizes, T4 kind of normalizes, but they still don't feel well. And so they're still tired, they're still fatigued, they still have chronic hypothyroid symptoms, and they get frustrated. And so then they start hearing that there's other options for thyroid medications. There's things like Armor and NP thyroid and other options that are available that have a combination of T4 and T3. And so that's I think a lot of people transition to integrative endocrinologists or integrative medicine specialists who do these kind of blended therapies or do T3 therapy. Now, those physicians are probably going to run a more comprehensive panel, because one of the big things they're taking a look at is if you've been diagnosed with hypothyroidism and you've been on T4 therapy and you've had your doses increased, decreased, they've been trying to manipulate your TSH to get you to feel well, but regardless of the amount of T4 you're on and regardless of your TSH, you still don't feel well. You still have chronic hypothyroid symptoms. And so the integrative physician will often take a look at T3 levels, and sometimes they'll take a look at reverse T3 as well. And what they're looking at is saying, hey, not only do we need TSH to normalize, but I think from their perspective, many of them are looking at it like, are you, the patient, converting that T4, whether your gland's making it or you're getting into medication, are you effectively converting it to T3, which is the active hormone? So I think the integrative physician is going to take a look at that piece of it. And T4, if you remember, can either be converted to T3, which is the active hormone, or it can be deactivated to reverse T3, which is essentially the less active or inactive form of T4. So, they'll look at those values. And then what they'll do is they'll say, okay, T4 is normal, but T3 is low, lab low, or functionally low, and free T3 is functionally low or lab low. So it doesn't look like you're converting really well. They'll also maybe take a look at reverse T3, and if reverse T3 is elevated on T4, they're going to say, hey, look, you have a conversion problem. You're not converting that medication or the hormone that your body's making efficiently from T4 to T3, and it's T3 that really supports the cells appropriately. So what we're going to do is we're going to give you either a blend of T4 and T3, or we're going to give you T4 as a medication and a separate medication of T3, which they'll often have you pulse throughout the day. And then some physicians will just prescribe T3. And maybe this works for some people, but what is the definition of works is all depends on what you're trying to achieve. So if you're the integrative physician and your goal is to increase T3 in the bloodstream, well, giving T3 will raise T3 in the bloodstream. If you're trying to reduce reverse T3, if you decrease the amount of T4 you give and increase the amount of T3, you're definitely going to reduce reverse T3 because there's less T4 in the system to be deactivated to reverse T3. The question becomes, is that treatment better for the client, better for the patient, better for you? And that all depends. You know, if the goal is, and the only thing you're looking at from that integrated perspective is, did I increase T3 and did I reduce reverse T3? Then you may say the treatment was a success. Just like the medical doctor may say the treatment was a success because I lowered TSH into range and improved T4. But ultimately, what we need to take into consideration is, what's the impact on the patient? Is the goal to normalize the labs, to essentially whack-a-mole, you know, the reverse T3 down and increase the T3, or should we really be taking a step back and asking a better question, like, how's the patient feeling on this therapy? And what I see, and I may be biased in what because I just see a lot of patients that have failed in both allopathic T4 therapies and failing in integrated practices where they're doing T4, T3, or just T3, or T4 and T3, and they're still struggling despite normal TSH, despite normal T4, despite normalized T3, they are still struggling. So maybe I have a biased subset of patients, and maybe I typically only see people that are failing. Maybe there are a lot of people that get T4, T3 therapy and feel fantastic. All their hypothyroid symptoms go away. Their weight goes back to normal. Their bowels work. Their libido's better. But I just see a lot of people who are struggling and are on T4, T3 combination therapy or T3 therapy. And to me, I think it's the wrong strategy. From that mindset or from that paradigm, their goal is to normalize the blood levels of T3 and reverse T3 and TSH and T4. And sometimes they're not even concerned about T4, they're just concerned about T3. And the thought is, as long as they normalize that, they're doing the best for the patient. I don't agree, and I don't think it really changes or diverts too far from what allopathic medicine is doing. So then it comes to functional medicine. So what might a functional medicine practitioner do differently? Well, functional medicine practitioner may do a lot of the same things that an integrated physician may do. They may run a comprehensive thyroid panel, TSH, T4, T3, free T4, free T3, reverse T3, T3 uptake, thyroid antibodies, maybe thyroglobulin. In the functional medicine practitioner, some kind of practice very similar to the integrated physician, but they say, listen, we're not going to use medications because the medications are bad, and we're going to use a glandular product. That's more natural, more healthy. I don't know if that's the right approach or strategy, but that's what somebody might do in a functional medicine perspective. They may look at thyroid antibodies and say, well, we have an autoimmune condition going on here, so I'm going to try and suppress your antibodies. I'm going to give you these supplements that are going to suppress the immune response. And the integrated physician may try and do that as well. They may give you some low dose naltrexone to try and suppress the immune response. They may do high dose vitamin D to lower antibodies. They may do treatments to kind of suppress the antibody response. And part of the reason for that is that it's kind of been thought or assumed that the thyroid antibodies are the problem, that the thyroid antibodies are causing the damage. And that does not appear to be the case based on the most recent science. The antibodies aren't the thing that's creating most of the damage. Thyroglobulin antibodies aren't supposed to cause any damage to the gland, and TPO antibodies maybe cause a small amount of damage to the thyroid gland. It's the infiltrating lymphocytes in the thyroid cells themselves that create the damage at the thyroid gland. So the thyroid antibodies are a reflection of the damage, potentially, that's going on at the gland, but they themselves are not the thing. So if you just suppress antibodies and prevent the body from making antibodies, are you doing the best for your patient? I don't know. If you believe that the immune system is out of control and you're suppressing the immune system because you believe the immune system has lost control, then maybe you are doing the right thing for your patient. So that goes back to the philosophy perspective. But I typically don't feel that the immune system is out of control as much as it is a calculated response to try and slow down metabolism globally in the body. But if we think about what functional medicine should do, in my opinion, when we're assessing and helping someone with thyroid physiology, what tests should we run? I think we should run the full thyroid panel. I think we should run all the tests that are available on the thyroid panel. And I think we should be looking at a comprehensive blood chemistry panel because as I went over on my Thyroid Thursday a couple weeks ago, we not only want to identify what form of hypothyroidism do we have, and I talk about the phases of hypothyroidism or the spectrum of hypothyroidism, but we also want to know, can the rest of the blood work kind of confirm that there's inflammatory mechanisms that would kind of be a reason why we might have this tissue and immune and glandular hypothyroid condition developing? Is there a reason, would that inflammation give us a reason why the body might be deactivating some of that thyroid hormone versus converting it to the active form? And we can use that comprehensive lab panel to kind of confirm that multiple tissues are in a hypothyroid state. And when we do that, not only do we have labs that kind of indicate that we have a tissue hypothyroid state, but we have labs that then indicate there's inflammation. And then we have labs that indicate that, yeah, the patient does have insulin resistance and they have reduced liver function and they have elevated lipids, all things that are typically associated with low tissue levels of T3, like a tissue or cellular hypothyroid state. So I think not only should all of the thyroid labs be looked at, but I also think a comprehensive blood panel should be run at the same time. Now, not all functional medicine practitioners do that. Many look, as I said, they look at that comprehensive panel, and they still look at that comprehensive panel as if the thyroid physiology is broken. Well, they may say, well, I'm going to give you a glandular product because the T4 and T3 medications don't work, but a glandular will work better. And then they're trying to give you a bunch of supplements that are going to drive or hopefully increase the conversion of T4 to T3. And they may give selenium, some glutathione, a number of other micronutrients that they believe are going to help the conversion. And the thought process is that if T4 to T3 conversion is diminished, then the person is probably deficient in one of the cofactors. And selenium is the big one you hear people talking about, that if you have decreased T4 to T3, if you just take a bunch of selenium and you take some glutathione, that'll help with the conversion of T4 to T3. Well, the enzyme that converts T4 to T3 is called type 2 deiodinase. There's actually 3 deiodinases: type 1, type 2, and type 3. Type 2, type 3 are kind of the primary drivers of the physiology. Type 2 is the primary activating enzyme. Type 3 is the primary deactivating enzyme. And so when I hear a functional medicine practitioner say the person has a conversion issue and I'm going to give them selenium to help with that T4 to T3 conversion, I always ask them, well, what's happening? Are they converting T4 to reverse T3? Well, yes, it's very high. Well, the deiodinase 3 requires the same selenium that the deiodinase 2 would need. So if it was if the deiodinase 2 wasn't working because of selenium deficiency, deiodinase 3 probably wouldn't work as selenium deficiency. So we wouldn't just see a low T3, we would see a low reverse T3 as well if it was a selenium deficiency that was preventing the deiodinases from working, because all of them would not work well. So that strategy, to me, I see it not often working very well. You'll see a number of supplements on the market that are like the thyroid support supplement, and that can be good. I'm not saying it's bad. There's a lot of cofactors there for thyroid function, but I think most people's thyroid issue has less to do with a selenium deficiency and more to do with a calculated response in the body to adapt to excessive cell stress when they're struggling with chronic hypothyroid symptoms. So another thing to consider when you're looking at what labs need to be tested is, what are you trying to achieve, right? So if your goal is to just normalize your TSH and T4, if that's what you're looking to do, then you only need a TSH and T4. If you're looking to identify if you have Hashimoto's, then you need to really look at TPO and thyroglobulin antibodies. If you're looking to identify if you have tissue hypothyroidism, which is what I talk about all the time, then you need to run more comprehensive panels. You need to look at the full panel. You want to look at the T4s, the T3s, the reverse T3. You want to look at all of that thyroid panel, and you want the rest of the comprehensive metabolic panel to look at, to see if there are signs of tissue hypothyroidism in other tissues. Is there indicators of inflammation? So I think it behooves you to think about what it is that you want, not just what your doctor wants. Because if you want to know if you have tissue hypothyroidism, then you better go to a physician who's actually looking for hypothyroid or tissue hypothyroidism, and not just trying to diagnose and address glandular hypothyroidism. So that becomes really important. So you got to find the person who's going to match what you want. When it comes to functional medicine and hypothyroid care, I think what you want to be asking yourself, and maybe the person you're looking for help with, is what is their goal and objective? Is it just to replace thyroid hormone like T4 with a blended T4, T3, or T3? Is it just to replace what medicine's doing? If that's what their goal is, and they're either using a glandular to replace T4, or they're using T4, T3 to replace the T4 therapy, or they're using just T3 to replace the T4 therapy, and their goal is just to replace those and normalize the blood values, I don't think that's functional medicine. I think that is maybe an integrative approach, and it may be different than what your allopathic physician is doing, but the concept is the same. That doctor, that physician is still trying to primarily normalize the blood values and not necessarily identify what some of those root issues are that are causing the body to behave the way it is, that's causing the thyroid hormone to be in this allostatic regulatory state versus the homeostatic state. So that becomes really, really important when you're trying to decide what should be run. You know, many times I get people sending me their TSH and T4. They think it's a comprehensive panel. They're like, what do I need to do? Like, I'm going to see something dramatically different than their medical doctor's going to do. And I'm telling them, listen, you have the signs and symptoms that you still have hypothyroidism despite a normalized TSH and a normalized T4. But those two tests alone aren't going to tell me what I need to know, which is, do you have tissue hypothyroidism? I can assume it because you still have hypothyroid symptoms, but it doesn't give me insight into what tissues are impacted. Do you have tissue hypothyroidism? What tissues are impacted and what might be causing it or triggering it? That requires more than looking at a TSH and T4. And you might think, well, how come my medical doctor can only has to look at those two tests and can make a decision what's wrong with me? Because he's only or she's only trying to diagnose primary hypothyroidism and to manage primary hypothyroidism TSH and T4 with one drug. In functional medicine, what we should be doing is taking a look at the patient and saying, okay, what caused this person's condition? And if we address the root cause issues, reduce the stress on the system, we don't have to manipulate the blood values with different medications or supplements. We just have to reduce the stress response, to reduce the stress on the cells and tissues so that the danger response goes away. And then thyroid physiology often goes back to normal, not because we manipulated the values by putting more or less hormone into the system, but because the body and the tissues and the cells are no longer in that danger response. And so now they do want more thyroid hormone to come into the system. They do want to convert more T4 to T3. They do want more T3 to bind to those receptors that are going to stimulate metabolism. And so I think it's the big challenge that most of you face when you're frustrated with your thyroid care is that you are asking somebody like an allopathic physician to do functional medicine, which is not even in their wheelhouse. You're asking them to do tests that they don't even do. You're asking them to change their treatment strategy that doesn't really, they never learned anything about what you're asking them to do. That's a foreign concept to them. So to them, it just sounds like craziness, okay? But the same is true when you come to a functional medicine practitioner and you say, I just want to know what is the supplement that's going to fix my thyroid physiology? Like what's the thyroid supplement that's going to fix it? What's the supplement that's going to fix my conversion? That's allopathic medicine. And that's where I think a good functional medicine practitioner is probably going to have to sit you down for a second and say, hey, my goal is not to there isn't a magic fix here. It's not typically a supplement deficiency that's causing you a problem, which usually causing the problem is some type of excessive cell stress. Maybe a dysbiosis or an infection or food sensitivities or food intolerances or trauma or emotional stress or toxicity or disrupted sleep patterns or disrupted respiratory patterns or a combination of all of those things are the things that are going to create the stress response that's going to change the physiology, okay? So I want you to really kind of get this idea and this concept that if you really want to get well, it's not about kind of band-aiding or masking symptoms or playing whack-a-mole with lab values to get them into range and that fixes your health. That doesn't. That I call whack-a-mole medicine. That's disease management. That's lab management. That's not functional medicine. That's not healthcare. That's really, really important. Your lab values aren't the problem. They're the indicator that there's a potential problem. So if you're frustrated in the allopathic model and you want to come to the functional medicine model, realize that there's not a simple supplement that's going to fix what's wrong. It's really a process of taking a look at your health history, your health timeline, the medications you take, the supplements you take, your blood chemistry, and maybe some specialized testing to determine what's creating the excessive stress response. How do we reduce that excessive stress response so the body can get out of a cell danger response and actually convert and move back into a cell healing, growth, and repair response? And when we do that, and we know which tissues have become dysfunctional because of this long-term chronic stress response, and we know how to nurture those tissues back to health, that's how we see people's health become restored. That's how we see people need to reduce their thyroid medications, because when you start to fix some of those root cause issues, what I see on a day in, day out basis is we have to get patients to go back to their prescribing doctors and have their doses reduced. I do it. It happens all the time. Right before I got on to start recording this podcast, I had a physician, a medical physician who's been fantastic to work with. We've reduced the patient's thyroid medication. I think we're on our third or fourth reduction of the dose as we've been working together to address the person's root issues And as we've started to fix those issues, their physiology has improved, and the thyroid dose they were on became excessive, caused more hyperthyroid type symptoms, and were good enough to be able to get the primary care to reduce the dose based on the patient's signs, symptoms, their weight loss, and what the lab values were showing. And I'm just lucky that I do have a couple medical physicians around me that are willing to listen to this functional medicine approach and open to make changes, not just based on what they learned in their guidelines and what straight up lab, where guidelines say about lab values, but to actually listen to me, the patient, and look at a broader panel and say, okay, let's give it a shot. I don't necessarily understand it all, what you're trying to tell me, but let's give it a shot. The patient is actually doing a little bit worse now on that high dose. Let's reduce that dose down, and we retest it 4 to 6 weeks later. We see the patient's doing better, and many times we see that now that even though we've reduced the dose, it's been 4 to 6 weeks, we've had more improvement, and the dose needs to decrease again, okay? It's not an unusual finding in my practice to see my patients have to continue to whittle down their thyroid medications, and for many of them to have to stop the medication altogether. Why? Because their thyroid physiology is working better. It's a beautiful thing to see, okay? So I think we get the gist of what's going on here. When we talk about what tests need to be run, it all depends on who you are going to see. You may see a medical doctor says only TSH and T4 is needed and appropriate. That's because of his paradigm, his guidelines, his goals, his objectives or her objectives in that allopathic model. You may see an integrated physician who runs a few more tests, and they're saying, hey, any of those other tests are not needed because it doesn't fit within their goals, their paradigm of thinking, and their treatment modality or their treatment structure. And then you may see a functional medicine practitioner who does a few more tests, but still says, well, I don't run that test, I don't run that test. That doesn't mean they're right or wrong. They're just focused. They're running the test that makes sense to them for what they're trying to accomplish. But to me, what makes the most sense to me and my bias is to run a comprehensive thyroid panel. All those tests have values. They all have vulnerabilities. There's all these things that can influence and make the test result maybe not as valid. But if we take the picture we look at, the more information we have to make better decisions on how to help the patients. What gets measured gets managed, but also what doesn't get measured doesn't get managed. So if your doctor only runs a TSH and T4, it doesn't look at a T3, they don't know that T4 isn't really doing a good job of converting to T3. They'll never know it because they didn't run the test. If they don't run a reverse T3, they can't see that they're probably on an excessive amount of thyroid hormone, or that the tissues are in a cell danger response and resisting the conversion of T4 to T3 and instead converting that T4 to reverse T3. So keep in mind that each doctor is going to run specific tests based on what their practice kind of strategy is, what they're looking for, what they're trying to correct, okay? But I do feel that the best model, because I am biased too, is to run a comprehensive thyroid panel and a comprehensive metabolic panel together, along with looking at the health history, the health timeline, their signs and symptoms, to come up with the best strategy to help. I will say this, because there's a lot of controversy sometimes around reverse T3. Should we be changing somebody's treatment? Should we be putting people on T3 therapy if their reverse T3 is elevated? I am not in agreement with that strategy, okay? It differs from what a lot of other people may think. But do I think reverse T3 is important? I do, because it tells me there's a level of tissue resistance, either because the patient's on too much thyroid medication or because the cells and tissues are in a danger response. But it doesn't mean I would want to change the treatment to a T3 therapy. I think that creates more problems. some people are going to have a honeymoon period maybe where they feel better when they switch from T4 to a T4 T3 combo or to T3 only, but I see more people having problems with the switch to T3 therapy if they stay on it for any length of time. Floods the brain. I think it creates too many problems, too much hyperthyroid symptoms, especially upregulating the sympathetic nervous system, insomnia, increased agitation, irritation, and it creates more peripheral resistance is what I've seen. I have many patients right now currently that we've had transition off their T4, T3 combination or T3 only back to a T4. And one of the things that they almost all of them mention is that they feel better, they're less stressed, they're less anxious, and a lot of them have seen their weight resistance start to improve. They've actually, when they went on T3, they actually maybe felt a little bit better, but then they started gaining weight again. Their physician was like, you can't be gaining weight, I'm giving you T3. Well, you can gain weight when you take T3 therapy because of a couple mechanisms, but it kind of proves the point. You just can't force more thyroid hormone into the bloodstream and assume that it's going to get into the cell and do what we want. Another concept that's really important is it's not how much T4, T3 that's in the bloodstream, it's how much T4 or T3 gets inside the cell. And I can't remember at this point if I said it already, but we think about T4 binding or T3 binding to receptors inside the cells and increasing cell metabolism, right? Cell growth. T3 also binds to receptors inside the cells and turns off the immune, the inflammatory, the cell danger response. And so when there's no stress on the cell, life is good, then the cell wants to increase growth and metabolism and energy. And T3 binds to the receptors in the mitochondria and the nucleus and turns on those growth and development processes. T3 binds to other receptors inside the cells and turns off that cell danger response. But when the cell perceives danger, there's a bacteria, there's a virus, there's a toxin, there's low oxygen, then it goes into danger mode. It goes into self-protection mode. And so T3 and T4 are deactivated, creating a net kind of low T3 state inside the cell. And what this does is it pulls T3 off receptors that are about growth and development and energy production. So that slows, and it pulls T3 off of the receptors that kind of regulate cell danger response. So when there's less T3 on those receptors, that actually turns on the cell danger response. When T3 binds to it, it actually turns off. So higher levels of T3 in the cell actually turns off the cell's defense response and turns on growth and development. I don't look at all this stuff as just broken physiology. I think it's by beautiful design. So keep that in mind. Your cells and tissues are probably doing what they're doing, not by accident, but because they're trying to protect themselves and trying to protect you. Just like a fever is not necessarily a bad thing. That's a protective response that we don't probably want to squash. We want to let the fever go because that's helping kill and upregulate the immune system and help address the bacteria or the infection or whatever's going on. We don't want to suppress it because that suppresses the immune response, okay? So if you have any questions regarding anything I talked about today on today's podcast, obviously reach out to me. Probably the best place to reach me, you can go to rejuvegencenter.com. If you have questions, if you want to discuss your individual situation, determine if scheduling a patient or scheduling an appointment with me might be appropriate, I have a link on my website to schedule a discovery call. It's a complimentary discovery call. It's about 15 minutes to have a brief discussion about your condition, your situation, and maybe I can give you some advice. And we can also talk, if you're looking for help, I can help you understand if it does make sense to try and schedule an appointment with me to help you. If you are looking for other places, you can get some of my content, my information. You can go to YouTube. I have Rejuvegen Center or Rejuvegen YouTube page. And then I guess where I'm most proliferative is on Instagram. So you can go to Instagram, it's Dr. Eric Ballcabbage. I try and get something posted at least 3-4 times a week. And if you message me, you can message me there. You can send me email to my office through my website. But if you have questions, You can always put those questions below wherever you watch the video or wherever you want see any of my posts, and I'll do my best to get back to you. Remember, sometime in this spring, the Thyroid Debacle book will be out, where you'll learn more about what I talk about and my co-author Kelly Halderman talk about. And what we're trying to do is we're trying to get people to think differently about thyroid physiology and how the body works, instead of always looking at what's going on as broken physiology. We really want you, regardless of the condition you have, to think of what's going on as adapted physiology. We want you to consider that if you address the underlying causes, and it's something that happened in your diet, in your lifestyle, in your habits, if you can identify those things and you can kind of reverse engineer the system, you can improve your health, whether it's hypothyroidism, insulin resistance, diabetes, cardiovascular disease. Almost anything can be improved if you address those root cause issues. And that's what the book is all about, is identifying a different way to look at physiology and foundational strategies to get healthy and get well. So take care, everybody, and stay tuned for another Thyroid Answers podcast in February. And share this podcast with your friends and your family. And if there's any topic that you want me to cover, just reach out to me and let me know. All right? Take care.